Good morning, everybody. This should be interesting because, of course, our ability to predict the future is none. So what I will do is at least start with something to inspire all of us. And I think from the perspective of if we want to see a future within our field, it involves all of us both being proactive with our own ability to try to push the envelope and get further with what we can do across multiple areas of bronchoscopy, but also to push the field in regards to people we collaborate with, whether that's other investigators, whether that's industry, whether that's venture capital to invest more money, to help people understand the true market that's available here. So if you can see it, this is what we're gonna get. So I'm gonna, and something changed. This was not the font I used, so when it got imported, so I apologize that the slides were cut off. This is my fault for using a flash drive instead of my laptop. So I just want to give you a microcosm of where we've been and where we were. We just watched an amazing video, of course, of where bronchoscopy has come from historically. I'll just give you the personal journey that I think all of us can reflect on in the short period of time that you've seen the massive growth in our field. So when the bronchoscopy program at the University of Chicago opened in 2004, I was given a space that was so small it had been rejected by GI for just upper endoscopies. They were storing equipment in it. We had no anesthesia. We had a therapeutic scope and 2 diagnostics, no EBUS or rebus. We had 1 brush, 1 forceps, and 1 needle. That's what we were allowed to stock. And we had just purchased Super Dimension, this novel new technology that had been out for a year or two, because we saw that possibility. So from a perspective, this is where we began. Now where we are now, you can't see it because it's been cut off due to someone changing my font, but it's actually, now we have 2 massive rooms, unlimited anesthesia, unlimited scopes, every device that's available on the market, and then some. So that's the possibilities. So where I'm going to touch very briefly, and this is going to be very high level. Obviously, I'm not going to go into a lot of specifics because some of these topics are going to be later talks. But let's talk about the future in regards to robotics, biopsy tools, imaging capabilities, the role of AI, the advancements in benign diseases, lung cancer therapeutics, ROSE, and then bronch training programs. Because I think ultimately from a future perspective, each one of these offers opportunities for our entire profession. So on the robotics side, right now there are 3 current platforms that are for sale within the US and in parts, some of them around the world. At the moment, there's more robots coming. 2 currently under development in China, and not counting any of the clones that are also going to be happening, and at least 2 under development in other countries. One that I can at least speak about personally that has the ability to detect and determine the degree of lung deformation with movement, the detection of atelectasis and scope manipulations of the airways, so ultimately built to correct for CT to body divergence inherently that occurs to able to essentially change with respiration. And offers up, I think, potentially an opportunity for the both delivery of the precision that we've expected with robotics, the ability to navigate, but also to compensate for all the dynamic movement that we see within the organ. So we'll see. All of these things continue to be the problem of prove it to me, number one, make it available at a cost perspective around the world so that it's no longer continues to be an issue of you can get this in certain countries, even in other countries you can get it only at select centers. There's a lack of the ability to apply robotics universally. That's still, I think, a major issue for all of us. Now, biopsy tools, I use the extractor for foreign bodies is not obviously anything new or interesting, but I used it only as a picture to model for a tool that's under development that essentially will come out and be able to turn at small angles and then spin and cauterize and essentially be able to try to remove a larger chunk of tissue. Obviously, it'll still be miniaturized because it's designed for a bronchoscope, but it's based off of some technology that's being used on cataracts and retina size. So a lot of the miniaturization that's going on in the eyes. And I think what's interesting about this whole component, other things you see up there, needle-tipped cryobiopsy tools, screw-like biopsy instruments, and then I'm going to talk briefly about the LIA tool that should soon be approved with an OCT stylus. But I think the recurring discussions that occur in a lot of the chat groups that exist around the world continue to be the problem that whatever technology you have used, whether it was a thin scope to a robot, to get to the lesion, the problem still remains getting adequate tissue to confirm a diagnosis. So briefly, a device that will soon be available is a needle with an OCT stylus built in off to the side, so that as you're inserting the needle into the tissue, you can spin it around and get confirmation that you are truly lesional. And then as you pull the stylus back, you'll still have some amount of a front view to be able to see the tissue quality. So as essentially a standard peripheral needle, but with an OCT stylus built in to give you the ability to see tissue in real time while you're sampling it. Now, that was the tools side. On the imaging side, obviously the beautiful thing about this has been the continued growth in the accessibility of advanced imaging systems, whether these are fixed cone beams, and I'm just showing one particular brand, but ultimately there's multiple players in this market. Mobile cone beams, which I think have also started to revolutionize this, and then ultimately a tool like body vision, which has been getting more and more access around the world and uses digital tomosynthesis. I think the value here, of course, across all three of these is that in some cases their ability to directly integrate with some softwares and directly integrate with even robotic platforms, but equally important, and I think as you even saw in the historical video when they were using bronchography and then using fluoroscopy at different angles, the ability to actually visualize the lesion in real time and its relationship to your instrument is also equally valuable. So this is an image courtesy of Mike Pritchett showing some early work that he has done with cone beam with a standard bronchoscope and then a hollow catheter to then ultimately take samples of lesions that are obviously far in the periphery to the limits as you saw the scope went, the catheter went the rest of the distance, but with confirmation and that you're in three planes. Mike and others have also looked at the ability to use cone beam with a software that essentially will allow you to navigate in not using a robotic-based platform, but essentially either catheter-based or scope-based, but to help guide you and give you additional overlays so that you can fluoroscopically guide yourself with a cone beam-based systems. Lung vision is another way to do this. This is augmented fluoroscopy, and others are going to talk about this, but to give you an overlay, an AI-enhanced image so that you can watch your instrumentation go into the lesion and in multiple planes so that, again, advanced imaging to add to where we are at. And it also gives you the capability to do this in 3 dimensions, this from a standard fluoroscopic instrument. And this is one of at least the powers that come from lung vision, which is able to use a standard C-arm to give you advanced views like this if you have limits on your ability to acquire the advanced imaging associated with cone beam. But I'd be remiss, as we're talking about the future, that maybe if we didn't root ourselves a little bit in the past. There's a link to this fantastic article by Dr. Ko, who is here and will be lecturing and doing workshops, who's, I would argue, is probably one of the profound leaders in the ability to do bronchial branch tracing navigation and being able to achieve profound results in Malaysia to help guide and get out further with thin scopes and use of radial probes and then additional tools like cryobiopsy, et cetera. And so maybe the answer isn't necessarily always robotics, isn't always necessarily advanced imaging, but it's an appropriate evaluation and study of your CT scan. Now, Ko's also been doing some work with advanced imaging to combine with his skill set and being able to drive out to the periphery of the lung. Now, let's talk about AI. Real quick, as you know, I had to put the Terminator up there, of course. And these are slides that have come from Vishist Mehta, who at least within the US is probably becoming the authority on the use of AI in bronchoscopy. So and there's a ton happening in this space, and there's going to be great lectures on this later, so I'm going to be very sort of high level on this one. But just wanted to show one example, and this is all it is. It's one example of an autonomous medical needle steering in vivo, and this is a porcine model. But the idea behind this was you bronchoscopically deployed a robotic steerable needle. So manually the scope went in and made a hole, but then ultimately this needle, through the AI algorithm of understanding everything with the CT and the vasculature and the airways, drove itself to the lesion. And what's interesting, it uses a field generator over the pig with sensorized fiducials to obviously track movement and then able to visualize as they drove virtually. This is the mechanism that was driving it off of an ambu scope. There was the manual bronching and piercing, then a teleoperated aiming, but then ultimately autonomous steering of this steerable, bendable needle through the airways. So a very similar driving mechanism that occurs with transparenchymal tunneling, but done autonomously. And I think what's fascinating is that they compared it to manual bronchoscopy. The operators did that versus the autonomous robotic driving of the needle. And what I'll draw your attention to was the ability to get out further with the needle, and that the targeting error was markedly smaller. If you look again at the robot, do I have a pointer? Well, you can see. The robot was able to get the needle insertion length on each attempt further and with a smaller radius and targeting error to hit the implanted nodule. So it's a fascinating concept of being able to then add an AI-based algorithm to what we're trying to do. Obviously, I think there'd still be some amount of manual involved. This is obviously profoundly early stage, but it's an interesting concept. And so then ultimately, when you see here, as they scanned, this was an explanted pig lung here, you can see the curve of the needle and the bending of the needle as through this aiming device to get the steerable needle out and scaving around blood vessels and getting ultimately to the lesion. Now, AI also plays a role in bronch education. This was a nice article that recently came out in ERJ Open Journal, looking at people using performing two bronchoscopies on a phantom using an AI training software from Ambu, their bronch simulator training guide. And it was novices, intermediates, and experienced folks using it. And the question would be is, while driving with AI helping to guide you, could you do a better job? And for the AI guidance group, they inspected more segments, they performed more structured progressions, and they spent more time on the procedure. So an argument right up front is that it provided external guidance, even for novices. And so the effect of AI guidance was highest for novices, as not surprising. But what it really offers from an education perspective, and arguably even a real world experience while doing it, was to ensure that from the very beginning, as good as we all like to think we are, that even the experienced users had better outcomes, or at least using the driving of this model. So it's an interesting concept. Now, how do we invite? It was a breadth of experience amongst these volunteers. It was a randomized crossover design. It's an interesting study. Again, I think a massive amount of potential. It's easy right now to just say AI will solve this. If you want to get your paper published, write the word AI somewhere in the title. It will get published automatically, it seems, these days. There's a lot of junk in this space, but I think some of these interesting early things at least show some promise of applications. I'll skip this, but there's a really nice editorial that recently also accompanied this article from Dr. Mehta, and it raises questions about the future of bronchoscopy on both the benefits, but then the concerns. I think on one level, people like to throw out the provocative statement that AI will replace all of us. I can at least say within the United States that the lawyers will ensure that the doctors will always be around, because you can't sue AI, you can always sue me. So now let's talk about benign disease. Let's deviate away from peripheral bronchoscopy and let's talk about what's happening in this space. So ongoing, of course, both in Europe and start in the US, the CONVERT trials for closing fissures to give us more access for the possibility of bronchoscopic lung volume reduction. Development of larger valves to close off an entire lobe, so we'd place potentially only one. Increasing elastic recoil, the Breathe 3 trials launching in the US right now. It's a new device, not a coil, conceptually similar. Still waiting for the results for rheoplasty, for the ability to try to decrease mucus production for chronic bronchitis. Targeted lung denervation may not have achieved its primary endpoints using heat. There's a cryo-based system that's ongoing studies around the world. And then re-resurrection of airway bypass using larger holes and larger stents to try to help hold things in place and keep things open. And again, many others. This was meant to be a broad overview. But I think this is also exciting because, without a doubt, while cancer continues to be the primary driver in bronchoscopy and always will be, the growing amount of severe airways-based disease around the world continues to rise with the steady increase in number of people smoking around the world. And even in the US, where smoking rates have been somewhat in decline, we're seeing higher smoking rates of both marijuana, which has been legalized, but also increased use of vaping, which is leading to other airways-based damages. So there's a lot of opportunity here as well. Now, I will spend not very long on therapeutics. This is the goal, I think, of all of us. This has been the so-called holy grail for us in bronchoscopy when it comes to lung cancer, which is to get to the periphery by whatever means, by whatever guidance, advanced imaging platforms, robotics, or the ability to use bronchial airway tracing, but prove that you're in the lesion and then do something about the lesion. Right now, obviously, we've been mostly diagnosticians, and then if we do anything so-called therapeutic, it's usually been very palliative, whether it's debulking a central tumor or putting a stent, et cetera, PDT aside. So this is, at least at the moment, the current options. You can use energy-based platforms, whether that's, microwave or RFA, then you can do cryo, chemotherapy directly into tumors, electroporation, PDT, brachytherapy, whether that is catheter-based or implantation, viral vectors, nanoparticles that enhance radiation, et cetera, or steam. All of these are on the table. And I think right now it's important. There's been I'll editorialize for half a second because that's kind of what I've been asked to do. There are a lot of people that are essentially right now trying to pick a winner, meaning they'll stand on a stage here and say, the single greatest way for us to treat cancer in the future is, X. Maybe. Show me the data. Prove it to me. Right now, everything that we're doing would, without a doubt, be considered experimental. And though there's some great anecdotes, everyone will pull out their, hey, we ablated with this, and this person's still alive. That's great. That doesn't prove anything to me. Not versus the standard of care of segmentectomies and SBRT. So real quick, this was ultrasound-guided injections of cisplatin for a patient that had used all their maximum amount of radiation and other therapy. They actually lived for another 2.5 years and then ultimately died of complications of pneumonia. And you can see on the PET activity, essentially destruction of the lesion. And why? Because when you give cisplatin, its actually accumulation in the lung is greater than the actual tumor. And so the idea of injecting cisplatin directly into the tumor is getting it actually where you want it. And this is all great work from Matt Kinsey, who I would argue is probably the authority on this within the US. And intratumoral cisplatin seems to augment immune therapy as well. And obviously immune therapy has changed a lot of what we're doing in this space. So there's a lot of, again, this is all early and there needs to be a lot more done with it, but it's still very exciting as an option for us. PDT, obviously in the periphery, you know how it works. It was talked about in the last video as well, but it's obviously been historically a tool for central airways and has plenty of limitations and toxicities. But the idea of exploring into the periphery, again, because we can have the reliability of being intralesional to then activate the laser. Microwave ablation, this is again pioneering work that Mike Pritchett and others, but very much Mike, have done for the endobronchial route, being able to actually obviously create a reliable kill zone. Here's some nice work from Calvin Eng as well with the imprint catheter. The Navablade study was at least an interesting, and I know Kelvin is here as well, and he'll be presenting on this, so I'm not trying to take away anybody's time, but ultimately the ability to show reliability and safety. I think, as you can see, especially when you look at the list of these authors, these are all people with profound experience, both with navigation, and advanced imaging to be able to reliably place these catheters. And that was the same thing that came out from the original trials of the microwave-based catheter for stage 1 lung cancer, recently published by Mike. And looking again at this small series, but technical success and efficacy was there. There was no tumor recurrence in the follow-up period. There was, unfortunately, an unexpected death related to the procedure, and it's put some major limitations on this, at least within the US. But still exciting, right? Still an interesting foray to be able to use the bronchoscope and other technology, the goal of being able to cure cancer from the inside, right? And especially as we keep finding more and more early carcinomas in younger people, at some point, we can't keep resecting out all this lung. Now, electroporation, Also some early stage technology, in my opinion, and no debate, way overpriced, but also is the ability for the destruction without extracellular matrix destruction, so cell death through pulsed electrical field energy. There's several people. This is data from Galvanize. It's one company in the space. They were able to show in some initial data technical success and safety, including biopsying things, or excuse me, treating things along vital structures or along the pleura without adverse events. And that was at least one potential appeal to this. And then on resection, as you can see, it seems to cause a massive immune activation and a lot of tertiary lymphoid structures. Now, whether this clinically ultimately matters outside of anecdotes remains to be seen. And then bronchoscopic thermal ablation also, though obviously depending on how far out you go, but offers the ability to do lung destruction through steam. So it's doing lung volume reduction, focus instead on tumor destruction. So ROSE, has its value. It also has its major limitations. It can increase diagnostic yield, decrease number of needle passes, et cetera. But there's a cost, and there's a lot of challenges. Huge variability in sample quality. It's cumbersome. The specimen preparation slow, extends your procedure time, and of course it involves pathology resources that many of us don't have access to. So I'm going to show up two that are at least available clinically. One is the ability to make the slides with the ASP device that then actually scans the image and then uses AI to assist in finding abnormal cells. It's very interesting when you look at the metrics of this automated slide producer, and it's probably only key finding. So it's either equipoise to a manual, but the key is the ability to create a good monolayer, that it actually had a superiority and ability to make a good monolayer to be evaluated. And then what it ultimately allowed you to do then was see better cell layer or cells without stacking to draw out the abnormalities so that the cytopathologist can actually better see the lesion and obviously diagnose the malignancy. A lot of nice publications about it and its ability to sample both lymph nodes and lung to give you rapid on-site evaluation in a purely automated way that can be run by anybody, so it's resource less intense. Now the additional technology I want to talk about is this problem of the fact that when you and I are biopsying things in the periphery, we frequently, of course, get necrosis, depending on the size of the lesion. And of course, necrosis, though a hint of an answer, is not an answer. And it's not an uncommon enough problem. But there's also the issue of, over and over and over, that we've proven our tool is in the lesion, but did our lesion leave from the patient and go into the tool? So it turns out, of course, that cancer glows on PET scan, as we all know, because of uptake of abnormal glucose. But it turns out that increased activity can also be measured at a microscopic level. And so the Van Gogh system uses full field optical coherence tomography and dynamic cell imaging to give you, literally as it scans through the whole piece, a heat map of the degree of metabolic activity of the piece that you've removed, all without touching the piece. And so you take your biopsy, put it in this device, and 2 minutes later, you get an image, as you see down there. Anything bright yellow is metabolically active. Anything not bright yellow is not. So in other words, if you've biopsied normal lung, you've got right up front proof that you missed. You biopsy necrosis, you've got proof that you missed. Without touching the piece, it scans the entire piece. So I'll give you an example. This is from Dr. Kovacs in Pennsylvania. A 73-year-old lady with a GGO. You can see it there, it's small. And on Van Gogh, the histopath view of it, you can see abnormal cells. You can clearly see metabolically active cells that are lining the airway stroma there. It would be consistent with an adenocarcinoma. So he took a couple of biopsies, had enough of this, a couple more pieces, and this is just one layer. It scans through. So he ended the case because he's like, all right, we've got diagnostic quality samples. And he gets a pathology report back. He doesn't have ROSE. So he gets a pathology report back a couple of days. It says, you got normal lung. We've all been there. He said, that's not possible. So he calls up the pathologist and says, I know I was in the lesion. Dig deeper. And as they dig deeper, they go, oh, yeah, no, that's a well-differentiated pulmonary adenocarcinoma. Because at the beginning of the biopsy pieces that he took, and these were cryobiopsies, he had a top layer of normal lung. But then as he got deeper into the tissue, the thing that he saw in the Van Gogh, and so voila. So he went back and then pulled cases that had been read as non-diagnostic and that had ultimately undergone another biopsy procedure, usually a resection. This was a recurring problem in his institution. It was a 12% rate of a misdiagnosis by the, quote, gold standard of pathology. Except in reality, the tissue had the diagnosis, it was buried in there. And the biggest way that he was able to push to use the whole sample was the ability to see, having scanned the entire piece intraoperatively. And these are some case examples. Again, here's that normal lung or whatever other tissue that you ripped out with your cryobiopsy, forceps biopsy, etc. And yet there's the sea of tumor glowing bright yellow. Same here as well. You can see these beautiful images. This is how you know right up front you got quality. So that's a nice tool, and others in the future. There are several other platforms that are also under development, some that are also in stealth mode. There's at least 3 others that we've been working with, and probably more, that are trying to help answer up front for us with a less resource-intense way. Now, training programs. Because of course, around the world, there are not enough of us, right? Everyone in this room that bronchs for a living, we're busy. We need more of us. So the only fellowship program in the US right now with 100% fill rates is interventional pulmonary. It is the most competitive fellowship offering within the US. There's been new IP fellowships in Sydney, Australia. Congrats to Taj for getting this approved. Obviously, ongoing fellowships in England, all around Europe, India, Malaysia, and others. And I apologize if I've missed your country and you have one. There's obviously differing levels of formality and standardization across all of these sites. And that is something that I think ultimately in the future, we need to start to harmonize what an IP fellowship actually means, what skills are we trying to impart, what are we trying to teach our people. But in India, at least, we've got continued growth and leadership coming from both Hari and Tinku and many others that are obviously really putting India square on the map for a growth in bronchoscopy. And so obviously the old song, "The Future's So Bright, I Gotta Wear Shades," there's an exciting time right now. I'm looking so forward. You know, the last 20 years of my career have been fascinating to see the development. I can't wait for the next 15. Not gonna be here in 20. So I'm gonna end with a thank you. This is the University of Chicago. If you find yourself in Chicago, I will make the shout out that the American College of Chest Physicians meeting, CHEST, is in October, and it will be in Chicago. So if you find yourself in the Chicago area, please come a little bit early, come watch some cases with us, and this is my contact information. Thank you so much, everybody. Appreciate the time.